Hi everyone, welcome back to Medi Notes for Medicos. The topic that we're going to deal today is about leprosy. Its objectives are the introduction, morphology of causative agent, Ridley-Jopling classification, WHO classification, paucibacillary leprosy, multibacillary leprosy, borderline leprosy, and intermediate leprosy, immunity, lab diagnosis, treatment, and the prophylaxis. Now, what is leprosy? Leprosy is a polymorphous, chronic, granulomatous infectious disease. The causative agent over here is Mycobacterium leprae. Its cultivation time is 12 to 13 days. Incubation period is 2 to 40 years. The transmission is done by nasal secretion, intimate or prolonged contact with the infected person. The areas involved are almost every areas are infected, especially the skin, the peripheral nerves, and the nasal mucosa. Now, how does a Mycobacterium leprae look like? It either is a straight or it's slightly curved rods having a size of 1.8 into 0.2 to 0.5 micrometer. It is bound in masses by lipid-like structures called globi. You can see over in the diagram over here, these are globi masses. Now, this globi, appears in undifferentiated histiocytes known as Virchow's lepra or formicelles. This is also known as the lepra cells or the formicelles. Now we'll be learning about the Ridley-Jopling classification. So according to Ridley-Jopling classification, leprosy can be divided into 5 different types. The polar tuberculoid leprosy, borderline tuberculoid leprosy, mid-borderline leprosy, borderline lepromatous leprosy, and polar lepromatous leprosy. So it's basically divided on number of lesions, the sensation, that is the nerve involvement in it, and also the uh, acid fast bacillus staining and skin smear test. So we'll be looking into each of it. So according to Ridley-Jopling classification, the number of lesions present in polar tuberculoid would be single usually. The size of the lesion would be variable, surface would be very dry, sometimes scaly. There would be absent in the sensations. There would be absent in the hair growth. Acid fast bacilli would be nil. In nasal scraping, it would be nil. Lepromin test would be strongly positive. And in borderline tuberculoid, the number of lesions would be single or few, variable size of lesions. The surface of the lesion would be dry. Sensation in the lesion would be moderately or markedly diminished. Then the hair growth would be markedly diminished. Acid fast bacilli in lesions would be scanty or might be nil also sometimes. In nasal scraping, it would be nil, and lepromin test would show weakly positive. And next is the mid borderline leprosy. Here number of lesions would be several, size of lesions would be variable, skin surface of the lesion would be slightly shiny, sensations would be slightly or moderately diminished, and hair growth would be moderately diminished. Acid fast lesions would be uh, moderate numbers. In nasal scraping or nasal blow would be nil, and lepromin test would be negative. When we go for borderline lepromatous leprosy, many number of lesions are seen and the lesion size is variable. The surface of the lesion would be shiny. Sensations in the lesion is slightly diminished. Hair growth in the lesion is slightly diminished. Acid fast bacillian lesions is many, and in nasal scraping it's usually nil. Lepromin test negative. When we go for the polar lepromatous leprosy, you can see the number of lesions are many, size of the lesions are small, surface of lesions are shiny, sensation is not affected or minimally affected, hair growth would not be affected, acid fast bacillian lesions are many, plus there would be globi. In nasal scraping also there would be many, plus the globi, and lepromin test would be negative. Next, we'll be looking into the WHO classification. So, according to WHO classification, there are 3 types of leprosy. That is lepromatous leprosy, uh, tuberculoid leprosy, and borderline or intermediate leprosy. So, according to this, we'll be looking into the nerve damage, the skin smears, and the number of skin lesions. So, according to a WHO, the borderline would have only one lesion, whereas the paucibacillary would have 2 to 5 lesions, and multibacillary would have 6 or more lesions. And in skin smears, it would be negative at all sites. Both paucibacillary and also the borderline tuberculoid would be negative, while the multibacillary would be positive at any site. In possibacillary, we would see an asymmetrical distribution, while in multibacillary, we would be seeing more symmetrical distribution. In borderline, we would be seeing a definite loss of sensation. In possibility also, but in multibacillary, there would be extensive sensation loss. In a borderline, we'd be seeing no nerve trunk involvement. In possibility, most probably one nerve trunk would be there. Multibacillary would have many nerve trunks. Now, Ridley-Jopling correlation, if we see, is like it is mostly correlated to polar tuberculoid leprosy, border tuberculoid leprosy, and mid-border leprosy. In possibacillary, it's mostly polar tuberculoid and borderline tuberculoid leprosy. In multibacillary, it can be border tuberculoid leprosy, it can also be mid-borderline leprosy, it can also be borderline lepromatous leprosy, and polar lepromatous leprosy. Now we'll be learning about the possibacillary leprosy. So possibacillary leprosy is also known as the tuberculoid leprosy. This is seen mostly in patients of high degree resistance. The skin lesions are few and sharply demarcated. You can see in this image how the skin lesions are sharply demarcated. These are the linings that shows the demarcation of the skin, and macular patches are there. Neural involvement occurs early and may lead to deformities, particularly in hands and feet. The bacilli is scanty in lesion. The infectivity is minimal. The cell-mediated immunity is adequate. The lepromin test shows positive. Extensive polyclonal B cell activation occurs. Mycobacterial and autoimmune diseases are seen. The prognosis is good, and the presence of CD4 plus cells is seen over here. Genetic predisposition is HLA-DR2. Albumin globulin ratio is usually reversed. Next is multibacillary leprosy. The other name of multibacillary leprosy is lepromatous leprosy. Here the hosts show low degree of resistance. Bacilli is seen in large number in lepra cells. Superficial nodular lesions, that is lepromata, develops. Bacilli shed in large number via the nasal and the oral secretions. It involves reticuloendothelial system, eyes, testes, kidneys, bones, etc. Leonine faces, like this faces are seen over here because of the involvement of eyes, nose, kidney, and all these things, especially the faces area. It gives a lion-like appearance, which gives the name leonine faces. They are more infective. The lepromin test shows negative. Cell-mediated immunity is deficient. The prognosis is very poor. Exaggerated broad humoral immune responses is seen. Antibodies are in high titers. Autoantibodies are common. The syphilis test, when we do for syphilis test, it shows falsely positive. And CD8 plus lymphocytes, genetic predisposition is HLA-MT1 and HLA-DQ1. Next, we'll be looking at the borderline and intermediate leprosy. Now, borderline leprosy is it possesses the characteristics of both tuberculoid leprosy and lepromatous leprosy. So it can either turn to tuberculoid leprosy or it can turn into lepromatous leprosy, and that's why it is also known as the dimorphous type. Whereas when we see intermediate leprosy, it can undergo spontaneous healing, or it might either progress into lepromatous or the tuberculoid leprosy. Next is the immunity. In these patients, high degree of innate immunity has been seen, and both the cellular and humoral immunity response are decreased. Now we'll be seeing the lab diagnosis. So basically we'll be taking 6 samples of specimen from the buttocks, the forehead, chin, cheeks, ears and sputum, nasal smear, slit skin smear, and nerve biopsy. For the microscopy, we would be doing acid fast staining for that, or it's also known as the Ziehl-Neelsen technique. 5% of the H2SO4 is used over here, and the bacteriological index would be 2. It cannot be cultured. We would be doing a mouse foot pad or armadillo. The serology would be antibody phenolic glycolipid antigen. For the treatment, it is a multi-drug therapy. For possibacillary lesions, we would be giving the patient rifampicin for 600 mg once in a month and dapsone 100 mg daily for 6 months. This would be continued minimum for 4 years. after and routine checkup should be done. For multibacillar relations, we will be giving them three drugs, that is rifampicin 600 mg once in a month, dapsone 100 mg daily for 6 months, clofazimine 50 mg daily for 2 years. In case clofazimine is not available or the patient is allergic to it, it can also be substituted with ethanamide or prothionamide. Now we can also give them immunotherapeutic vaccine, that is mycobacterium W, to enhance the effect of multi-drug therapy. Now for the prophylaxis, we'll have to find the case and then the adequate therapy. So finding the case in the sense is to identify which sort of leprosy it is. Also because it sometimes lepromatous leprosy shows the characteristics of syphilis too, syphilis in its tertiary stages. So and also it shows a positive, false positive. So it turns difficult to identify if the disease is actually syphilis or leprosy. And so it says for the prophylaxis we need to find the cases and then provide the adequate therapy. We can also give them long-term chemoprophylaxis, and BCG vaccine is a new study that is coming up. It is basically given to the patients because the scientists or the researchers say that mycobacterium bacilli and leprobacilli, they show some sort of antigenic relationship, so it might act as a prophylaxis against leprosy. So that was for today. I hope you like this video. If you like this video, don't forget to like, share and subscribe to the channel. We'll be coming with more videos. Till then, stay tuned. Happy learning. Bye.